Okay, hi, good night, everyone. My name is Celine Lachman. I'm one of the neurosurgery house officers at San Fernando, and tonight I'm going to be presented on circumscribed astrocytic gliomas. In the last class, Dr. Bellotto would have presented on the diffuse gliomas in the pediatric and adult population. So tonight we'll be talking about the circumscribed gliomas. Now, when compared to the diffuse gliomas, these tumors are typically well defined, meaning that their boundaries are relatively clear. They, unlike the more infiltrative forms of gliomas that spread diffusely into the surrounding brain tissue. So essentially, they have a more contained growth pattern, which would differ from the infiltrating gliomas. In this presentation, we're going to be covering pilocytic astrocytomas and its subtypes, as well as based on their location, the high-grade astrocytomas with pyloid features, pleomorphic xanthoastrocytomas, subependymal giant cell astrocytomas, choroid gliomas, and the astroblastoma. Now, with respect to the pilocytic astrocytomas, which are WHO grade 1, they comprise 5% of the primary brain tumors and were previously referred to variously as a cystic cerebellar astrocytoma or a juvenile pilocytic astrocytoma because they are the most common glioma in pediatrics, with usually presenting during the second decades of life, around ages 10 to 20, which accounts for about 75% of patients would be less than or equal to 20 years of age with a slightly male predominance. Now, most of the PCAs are sporadic, but it is a main tumor in neurodevelopmental diseases with germline mutations in the MAPK pathway or the mitogen activated protein kinase pathway genes, which would include conditions like NF1 or neurofibromatosis type 1. It has a better prognosis of about a 10-year survival rate, more than 95% than the infiltrating or diffuse astrocytomas. And they can be based on their location as well, like the optic gliomas, hypothalamic gliomas, and the cerebellar PCAs, which we'll go into each one in the subsequent slides. And there have also been two subtypes that have been identified, which would be the pylomyxoid astrocytoma and the pilocytic astrocytoma with histological features of anaplasia, which we'll also talk about these. With respect to the molecular genetics, so the most common genetic abnormality in the PCAs is the BRAF gene, which activates the MAPK pathway, and this is involved in nearly all of the PCAs, but is most prevalent, about 75% in the cerebellar PCAs. Now, if we look at the diagram on the side, this is the diagnostic criteria for the pilocytic astrocytoma, which we'll talk about the histological features in the next slide. But again, to mention, about 15 to 20% of patients with NF1 will develop PCAs. So it's the main CNS tumor associated with NF1, as we said. With respect to histology, now PCAs are usually histologically WHO grade 1. However, a rare anaplastic form in adults had been identified, but a WHO grade 3 variant is not officially recognized. When talking about microscopy, there are two main cell populations that have best been appreciated in the cerebellar PCAs. So the first one is cells with a long, thin bipolar processes, which resemble hairs, so hence the name pilocytic, with rosental fibers, which you'll see on the diagram on the side, which are essentially like sausage or corkscrew shaped, and they are cytoplasmic eosinophilic inclusion bodies consisting of glial filament aggregates resembling hyaline, and they stay in bright red on the Mason trichrome smears. The second set of cells that we see or tissue is loosely knit tissue comprising of stellate astrocytes with microcysts and occasional eosinophilic granular bodies, which is the picture on the bottom. Now, it's important to note that pathology alone may not be able to differentiate these from a diffuse or infiltrating astrocytoma. So, especially problematic with smaller specimens like obtained with stereotactic biopsies. So, we use things like clinical features like a young age, also the knowledge of the radiographic appearance, which would be critical in these patients, which we will go through again in the next slides. With respect to malignant degeneration, it is rare, but it has been reported and often after many years. And there was also an association with radiation therapy that had been administered in most of these cases, although it can occur without radiation as well. Now, with respect to imaging, preoperatively, an MRI of the entire neural axis, so brain and whole spine, with and without contrast, is usually indicated for these patients. On a CT or MRI, it's usually well circumscribed. About 94% of them enhanced with contrast, unlike most of the low-grade diffuse astrocytomas. And frequently, they have a cystic component with a mural nodule. Now, if we look at the picture seen here, this is a pilocytic astrocytoma in the posterior fossa of a child, classically presenting as the cyst, which is the red arrows, with an enhancing mural nodule, which is the yellow arrows, with yellow arrow. Now, the cyst wall, is important to note, may or may not enhance. They may have little or no surrounding edema. And when based on the location, so for example, if it's in the optic apparatus, this pattern is usually fusiform, and we'll talk about it more when we reach to that location. Now, this table shows essentially some imaging characteristics of the cerebellar or cerebral PCAs and their percentages. So in about 21%, you can see a non-enhancing cyst with an enhancing mural nodule. 46%, you can see an enhancing cyst with the enhancing mural nodule. 16% can have a mass with a non-enhancing central area or necrosis. 17% with a solid mass with minimal or no cysts, but over 66% are cystic with the enhancing mural nodule from the picture that we saw. Treatment now. So the treatment of choice is surgical excision of the maximal amount of tumor that can be removed without producing deficit. However, invasion of the brainstem or involvement of the cranial nerves or blood vessels may limit the resection. In tumors composed of a nodule with a true cyst, excision of the nodule alone is sufficient and the cyst wall need not be removed. But in tumors with a so-called false cyst, where the cyst wall is thick and enhances on imaging, this portion must also be removed. With respect to the role of chemotherapy and radiation in these patients, because of the high 5 to 10-year survival rates, coupled with the high complication rates of radiation therapy over this time period, things like radiation injury and necrosis, and the fact that many of the incompletely resected tumors enlarge minimally, if at all, over the next 5, 10, or 20 years, it is recommended to not radiate these patients post-op. Rather, they should be followed with serial CTs or MRIs and be reoperated if there is recurrence. Radiation, however, is indicated for the non-resectable recurrences or for recurrences with malignant histology. Important to note, though, that chemotherapy is preferred to radiation in younger patients. With respect to the prognosis, the natural history of these tumors is slow growing. Survival rates at 5 and 10 years at 95% after the surgical resection alone. Tumor recurrence is relatively common, and although it had been said that they generally occur within 3 years of the surgery, this was proven to be controversial, and very late recurrences have been documented. Some of the tumors that are excised partially, they fail to show any further growth, and it represents a form of cure, so long-term progression-free survival. To note, about 20% of the cerebellar PCAs develop hydrocephalus requiring further treatment following the surgery, and the so-called drop mets these rarely occur with the PCAs. With respect to these subtypes now that we would have mentioned, the pylomyxoid astrocytoma is a tumor of infancy that develops in the hypothalamic or chiasmic region and carries a higher rate of recurrence, worse outcome, and tendency for CSF dissemination. So here in this diagram would be the diagnostic criteria. Again, they are comprised of monomorphic pyloid cells. They have a diffusely myxoid background and increased cellularity and angiocentric cell arrangements. By definition, they do not contain the rosenthal fibers or the eosinophilic granular bodies that the classic PCAs would contain. And they may eventually morph into a classic PCA, and also they can occur in the spinal cord. The second subtype that was identified was the pilocytic astrocytoma with histological features of anaplasia, similar to the PCA, but also possesses mitotic features and with or without necrosis. These anaplastic features can be present on the initial analysis, or they can also develop later. Right, so now we'll further subdivide it based on the location. So about 42% can be found in the cerebellum, 35% in the cerebral hemisphere. The optic gliomas and the hypothalamic gliomas account for about 9%, and 9% in the brainstem PCAs, and 2% for the spinal cord. So they can arise essentially throughout the neural axis. So pilocytic astrocytomas of the cerebellum, they are often cystic, formerly referred to as cystic cerebellar astrocytomas, and half of these have a mural nodule. They again usually present during the second decade of life, ages 10 to 20. They are one of the more common pediatric brain tumors, accounting for about 15% of primary brain tumors in patients less than 19 years of age, and 27 to 40% of the pediatric posterior fossa tumors. But they can also occur in adults where the mean age for these patients would be lower and the post-op survival is longer than that of the diffuse gliomas. So these typically present as how a posterior fossa mass would present. So symptoms of like hydrocephalus, so headaches, nausea, vomiting. They can also have cerebellar dysfunction like ataxia, cranial nerve deficits. And then on the features on the MRI, so again, posterior fossa cyst with an enhancing mural nodule. Again, the cyst wall sometimes enhances, usually as a thin rim. With respect to the features of its pathology now, it has it's macroscopic cystic architecture and it has a microscopic spongy appearance. They can be solid, but they are often more cystic with the mural nodule, and they tend to be large at the time of diagnosis, where the cystic tumors are anywhere from 4 to 5.6 centimeters in diameter, the solid tumors 2 to 4.8 centimeters in diameter, and to note, the cysts contain highly proteinaceous fluid as well. Treatment. So for the cystic cerebellar PCAs, the excision of the nodule without removing the cyst wall is sufficient. Also, because of the high frequency of the BRAF abnormalities, research is ongoing to evaluate the efficacy of the BRAF and/or MEK inhibitors. So the second location that we'll look at now is the optic pathway gliomas. Now, this can occur anywhere along the optic pathway from the optic disc to the occipital cortex. It accounts for about 2% of gliomas in adults and 7% in children. The incidence is higher, about 25% in neurofibromatosis type 1 patients. And there is something called a Dodge classification, which divides these tumors into just 3 groups based on their anatomical location. So the first one is where it involves one optic nerve without chiasmal involvement. More than about 25% of these are confined to the optic disc and the nerve. The second one is pattern is in the optic chiasm, which is about 40 to 70%. Now, these are less commonly involved in patients with NF1. So it's usually sporadic, it is aggressive, and about 33 to 60% also invade the hypothalamus or the third ventricle. Now, the third pattern, which is the multicentric in both optic nerves, but sparing the chiasm, this one is seen almost exclusively in NF1 and can occur in conjunction with or be part of a hypothalamic glioma, which is why it is a bit difficult to distinguish these from a hypothalamic glioma, and usually a biopsy is needed, but we'll talk about that as well. So with respect to how this histology and presentation, now, they are composed of low-grade pilocytic astrocytes, and rarely a malignant chiasmal glioma will occur. Presentation, so they usually remain asymptomatic, but painless proptosis is an early sign of the lesions involving one of the optic nerves. In the chiasmal lesions, they can have variable and non-specific visual deficits, like usually monocular without proptosis. For the large chiasmal tumors, the hypothalamic and pituitary dysfunctions can occur and may produce hydrocephalus by obstruction at the foramen of Monro. And then on fundoscopy, you could see gliosis of the optic nerve head as well. So with respect to imaging, CT or MRI, again, I had mentioned this before, you could have involvement of the optic nerve producing a fusiform enlargement of the nerve, usually extended more than 1 centimeter in length. So for the optic pathway gliomas in patients with NF1, which typically isolated to the optic nerve, whereas those not associated with NF1 would be the ones involving the chiasm, can extend outside the optic apparatus and are frequently cystic, and enhancement is usually only mild to moderate. So for a tumor involving a single optic nerve sparing the chiasm but producing proptosis and visual loss, a transcranial approach with excision of the nerve from the globe all the way back to the chiasm can be done. For the chiasmal tumors, these are generally not treated surgically except for biopsy, especially when it's difficult, again, to distinguish the optic nerve glioma from the hypothalamic glioma. Surgery can also be in the form of the CSF shunting or to remove the rare exophytic component to try and improve the vision. Role of chemo and radiation. Now, again, chemo is preferred over radiation in the younger patients, and indications would be the chiasmal tumors, multicentric tumors, post-op if the tumor is found in the chiasmal stump end of the resected nerve, or for a malignant tumor, which is rare. Now, the next location, which would be the hypothalamic gliomas, the pilocytic astrocytomas of the hypothalamus and the third ventricular region occur primarily in children. Radiographically, the lesions can have an intraventricular appearance, and many of these tumors have some chiasmal involvement, and as we said, a distinction from the optic nerve glioma cannot be made. Possible presentations can include something called diencephalic syndrome, which is a rare syndrome seen in peds, usually caused by an infiltrating glioma of the anterior hypothalamus, classically presenting with cachexia, failure to try, failure to gain weight, hyperactivity or over alertness, and almost euphoric affect in contrast to their gaunt appearance. They can have endocrine disturbances like hypoglycemia, diabetes insipidus with hypernatremia, precocious puberty, and they can also have symptoms related to hydrocephalus, macrocephaly, headaches, nausea, vomiting. Treatment for these patients, when complete resection is not possible, adjuvant therapy may be needed as outlined under the optic gliomas before. So the next location now would be the brainstem gliomas. These comprise about 1% of adult tumors. They tend to occur during the childhood and adolescence period. About 77% are less than 20 years of age, and they comprise about 10 to 20% of the pediatric CNS tumors. So how they present now is essentially so because of their invasive nature, their signs and symptoms usually don't occur until the tumor is fairly extensive in size, but we can do it based on their location. So for the upper brainstem tumors, they tend to present with cerebellar findings and hydrocephalus, whereas the lower brainstem tumors tend to present with multiple lower cranial nerve deficits and long tract findings. So the signs and symptoms we could see would be things like gait disturbances, headaches, nausea, vomiting, cranial nerve deficits like diplopia, facial asymmetry. 30% may have distal motor weakness, papilledema in 50%, hydrocephalus in about 60%, and is usually due to aqueductal obstruction, which is often late, except with periaqueductal tumors, and failure to thrive, especially in less than or equal to 2 years of age. Now, with respect to its pathology, there may be a tendency toward lower grade tumors in the upper brainstem. About 76% were low grade versus the lower brainstem, where 100% of the glioblastomas were in the medulla. Now, a cystic component is rarely seen, and calcifications are also rare, but on MRI, there had been 4 growth patterns that were identified. So the first one was being diffuse, meaning that all are malignant, most are anaplastic astrocytomas and the rest are glioblastomas, but on MRI, these tumors extend into the adjacent region in the vertical axis. So for example, the medullary tumors extend into the pons and or the cervical cord with very little growth towards the obex remaining intraaxial. The second growth pattern was cervicomedullary, which are most, about 72% are low-grade astrocytomas. The extent of these tumors is limited to the spinomedullary junction, and most bulge into the obex of the fourth ventricle. Some may have an actual exophytic component. The third growth pattern that was recognized was focal, where the extent is limited to the medulla. It does not extend up into the pons or down into the spinal cord. Most are, about 66% are low-grade astrocytomas. And then the fourth growth pattern would have been the dorsally exophytic, which may be an extension of the focal tumors, and many may be low-grade gliomas, including pilocytic astrocytomas or gangliogliomas, which are rare. Compared to the other brainstem gliomas, deep gangliogliomas, these patients tend to be slightly older, and the medulla is involved more frequently. So with respect to imaging, MRI is the diagnostic test of choice. It evaluates the status of the ventricles, can give optimal assessment of the tumor and detect the exophytic component. On a CT, most of these do not enhance except possibly the exophytic component, but if there is marked enhancement on a CT, then we should consider other diagnoses. So surgery in the form of a biopsy, so for diffuse non-exophytic infiltrating tumor, this was discouraged, but because of change in trends, now they are leaning towards biopsy even when the MRI shows a diffuse infiltrating brainstem lesion, and this is to look for the H3K27M mutation, but treatment is usually non-surgical. But the exceptions where surgery may be indicated would be tumors with a dorsally exophytic component, which could protrude into the fourth ventricle or the CP angle, and these tend to enhance with IV contrast, and they tend to be lower grade. Also, some success has been achieved with non-exophytic tumors that are not malignant astrocytomas, and shunting the next indication would be shunting for the hydrocephalus. Treatment continued. So for the dorsally exophytic tumors like the gangliogliomas, these are amenable to radical subtotal resection. Surgical goals for the exophytic tumors would include enhanced survival by subtotal removal of the exophytic component, establishing, so these tumors are generally histologically benign, but surgery to establish diagnosis, because radiographic differentiation from the exophytic brainstem glioma tumors from other lesions like the medulloblastomas, ependymomas, dermoids may be difficult. And then tumors that demonstrate recurrent growth after resection also remain histologically benign and were amenable to re-resection. But in non-surgical treatment and prognosis now, so medically, no proven chemotherapeutic regimen had been noted, but there was some indication of a response to temozolomide, which is an alkylating agent, and also steroids are usually administered. With respect to radiation now, it's usually done over a 6-week period, 5 days per week. When combined with the steroids, symptomatic improvement occurred in about 80% of patients, and there was possible improved survival with so-called hyperfractionation, where smaller doses of the radiation per day were used. Prognosis now. So unfortunately, most children with malignant brainstem gliomas will die within 6 to 12 months of the diagnosis being made. Radiation may not prolong survival in patients with a grade 3 or 4 tumors, and a subgroup of children, though, have a more slowly growing tumor and may have up to 50% of 5-year survival. The dorsally exophytic tumors composed of the pilocytic astrocytoma, so we may have a better prognosis. Now we're going to look at the tactile gliomas. So they are considered a benign subgroup of the brainstem gliomas. They are generally low-grade astrocytomas. Because of their location, they tend to present with hydrocephalus, and this group was dramatically referred to previously as the smallest tumor in the body that could lead to death of a patient. They can present with focal neurological findings, which are rare, like diplopia, visual field deficits, nystagmus, paranoid syndrome, which is a triad of up-gaze palsy, convergence, retraction, nystagmus, and pupillary hyporeflexia. And these symptoms are often reversible after the hydrocephalus is corrected. But with respect to the they can also present with ataxia and seizures. With respect to the epidemiology now, they comprise about 6% of surgically treated pediatric brain tumors, presented primarily in childhood, with a median age of these symptoms starting around 6 to 14 years of age. Now, since many of these are not biopsied, meaningful statistical analysis is not possible, but pathologies that have been identified include WHO grade 2 diffuse astrocytomas, pilocytic astrocytomas, WHO grade 2 ependymomas, anaplastic astrocytomas, oligodendroglioma, and oligoastrocytomas. With respect to imaging now, so CT can detect the hydrocephalus, but can miss the tumor in about 50% of cases. Calcifications on CT have been described in about 9 to 25%, but MRI is the choice for diagnosis and follow-up. They typically appear as a mass projecting dorsally from the quadrigeminal plate, is iso-intense on T1 weighted, iso or hyper-intense on T2 weighted. Enhancement with contrast occurs in about 18% and is of uncertain prognostic significance. Now, with respect to the treatment and the prognosis of these patients, so due to the indolent cause, open surgery is not recommended. So options can include in the form of a VP shunt, which is the standard treatment for years. Long-term results are good with a functioning shunt. Then you can have endoscopic third ventriculostomy, which may avoid the need for a shunt. And an endoscopic biopsy may be done at the same time through the same borehole if it is technically feasible, but it requires a dilated foramen of Monro, which is usually present in these patients, but long-term results are unknown. The third one could be endoscopic aqueductoplasty, with or without stenting is an option for some. Again, long-term results unknown. And then stereotactic radiosurgery may be offered for tumor progression, but the criteria is not defined. With respect to the tumor progression now, is described in about 15 to 25% of patients, and follow-up is, so essentially there's no accepted guidelines, but serial exams and MRIs every 6 to 12 months is what is suggested. If we look at the picture on the side, so this is a tactile glioma causing hydrocephalus in a 14-year-old boy. In picture A, this is a sagittal T1 weighted MRI of the brain, which demonstrates the tactile mass seen by the arrow. And in picture B, this is a sagittal steady state T2 weighted MRI showing aqueductal obstruction from mass effect, which is the longer arrow, and dilatation of the third ventricular recesses, which are the shorter arrows, indicating hydrocephalus. In this case, this boy was treated with endoscopic third ventriculostomy. Right, so now we're going to talk about the second type under this category, which would be the high-grade astrocytoma with pyloid features. Now, this is a rare astrocytoma that often shows high-grade pyloid and or glioblastoma-like features possessing a distinct DNA methylation profile, which if you look at the picture on the bottom, this is the diagnostic criteria fit. So that's one of the features. And these tumors can arise de novo, but they can also develop from lower grade astrocytomas, including the pilocytic astrocytomas. And prognostic information is limited with a overall 5-year survival of about 50%. Next, we're going to look at the pleomorphic xanthoastrocytomas, which are WHO grade 2 or 3. They are thought to arise from the subpile astrocytes, which may explain their superficial location and the abundance of the reticulin fibers. Over 90% are supratentorial, and they have a predominance for the temporal lobes in about 50% of patients, followed by the parietal, occipital, and then the frontal lobes. They often have a cystic component, but they may be multiloculated, but 90% of these have a large single cyst. They account for about 1% of the astrocytomas, usually occurring in children or young adults, most less than 18 years of age, with no gender difference. They have a high prevalence of the MAPK pathway alterations, which explain the association again with NF1. And clinically, their usual presentations are with seizures, but they can also produce focal deficits or features of increased ICP. With respect to histology, again, so a couple of different phenotypes have been seen, but a compact superficial tumor, usually circumscribed, occasionally infiltrating the cortex, and marked cellular pleomorphism, which are fibrillary and giant multinucleated astrocytes, large xanthomatous or lipid-laden, may cause these tumors to be mistaken for an anaplastic astrocytoma as well. You can also see abundant eosinophilic granular bodies, reticulin, and frequent perivascular chronic inflammatory cells. Now, the reticulin fibers surround two cell types, which is in the picture on the top. So the spindle cells, which are fusiform cell-shaped with elongated nuclei, and then pleomorphic cells, which are the round cells with the heterochromic pleomorphic nuclei that may be mononucleated or multinucleated. With respect to grading now, so most of the PXAs are WHO grade 2, but if they have a high mitotic index, this qualifies as a WHO grade 3, and necrosis is more common in the grade 3s. They also have a tendency to recur and undergo anaplastic change, and there have also been several reported cases of malignant transformations and anaplastic astrocytoma or glioblastoma. With respect to molecular genetics, almost all demonstrate an abnormal activation of the MAPK pathway due to genetic alterations, but the most common alteration is in the BRAF V600E, and when seen in the absence of the IDH mutation, which is the isocitrate dehydrogenase, this is strongly supportive of the diagnosis. With respect to imaging now, so since CPXAs tend to disseminate when they progress, a whole spine MRI as well is recommended at the time of clinical progression. So the cyst, when present, may partially enhance on CT or MRI. A mural nodule is present in about 25% of the cases. They may have a dural tail in about 67%, which shows leptomeningeal involvement. 13% shows involvement of all three meningeal layers. Peritumoral edema may be mild to moderate, and calcifications are also rare. So with respect to the CT, the solid portion of the tumor is ill-defined and may be isodense to gray matter, but with the MRI on a T1 weighted is hypointensive tense cystic components with ill-defined iso-intense solid components that strongly enhances with contrast, and then on a T2 weighted hyperintense cystic components with ill-defined iso-intense solid components. So with respect to the treatment and prognosis now, surgery is the primary treatment. A gross total resection, if it can be accomplished without unacceptable neurological deficits, is preferred. Otherwise, subtotal resection. The extent of the resection is important, is most strongly associated with the recurrence-free survival. And then incomplete resections need to be followed closely since these tumors grow very slowly over many years before retreatment is necessary. And at that point, a repeat excision should be considered. So the role of radiation therapy is controversial, but the literature suggests that there's either no difference in the overall survival or possibly a trend towards prolonged survival. It needs to be considered with residual disease in a high mitotic index or necrosis. And then chemotherapy, the role is not defined. Now, the extent of resection, mitotic index, and necrosis appear to be the best predictors of outcome in these patients, which we're talking about prognosis, they frequently recur and malignant progression is more common than other WHO CNS grade 1 or 2 gliomas in younger patients. They have about a 5-year recurrence-free survival, 71% for the grade 2s and 49% for grade 3s. And the overall survival is 54 months for the grade 2 versus 33 months for grade 3. Next, we're going to talk about the subependymal giant cell astrocytomas, which are circumscribed, often calcified, WHO grade 1 tumor having a strong association with tuberous sclerosis. So it is unclear if these subependymal giant cell astrocytomas develop in the absence of this condition. Its incidence in these patients is about 5 to 15%, and they rarely occur de novo after 25 years of age. They typically possess inactivation of the TSC1 on the TSC2, and then deficient tuberin and harmatin expression are also observed with these mutations. With respect to their location, they arise from the lateral walls of the lateral ventricles next to the foramen of Monro, and they are rarely found in the third ventricle. With respect to histology and prognosis, again, the diagram shows the diagnostic criteria, but with respect to the histology, you can see large plum cells resembling Astrocytic astrocytes, which are common, arrayed in fascicles, sheets, and nests. Polygonal cells with ample cytoplasm may be seen, and then areas of necrosis and mitotic figures may also be seen. Now, treatment and prognosis, a gross total resection is associated with a favorable prognosis. However, larger lesions or symptomatic lesions have an increased risk of surgical morbidity. Everolimus, which is a type of targeted drug called an mTOR blocker inhibitor, it may reduce the tumor size and progression. And also, because of the risk of late recurrence, the long-term follow-up is recommended. Now we're going to talk about the choroid gliomas, which are WHO grade 2. So it is a glioma that occurs in the anterior third ventricle, possibly arising from the tanocyte ependymal cells. They comprise of about less than 0.1% of the primary brain tumors, typically occurring in adults with a female predominance of 2 to 1. So they can present with features of obstructive hydrocephalus with typical symptoms of headaches, nausea, vomiting, obtundation, endocrine disturbances like hypothyroidism, amenorrhea, diabetes insipidus from compression of the hypothalamus, visual field deficits from compression of the chiasm, psychiatric symptoms like personality changes and memory disturbances. So how we evaluate these patients now? So an MRI, which are well circumscribed mass, which is iso-intense to brain on T1 images with avid enhancement located in the anterior third ventricle, and large tumors may even occupy the entire third ventricle. With respect to histology, they are typically comprised of clusters of cords of epithelioid cells embedded in a mucinous stroma, and GFAP immunohistostaining is common. Mitotic activity is absent in most. With respect to the treatment, maximal safe resection is the primary treatment modality. However, if there's attachment to the wall of the third ventricle or the hypothalamus, this may prevent total removal. Post-op adjuvant therapy with radiation is of uncertain benefit. And then the last one we're going to talk about is the astroblastoma, which is WHO grade 1. It is a circumscribed glial tumor with MN1 alteration. It occurs almost exclusively in females with a median age of about 15 years, but can range anywhere from 3 months to 40 years of age. The location is primarily in the cerebral hemispheres, typically in the frontal or parietal lobes, but can also occur in the occipital or temporal lobes. And there has also been described in the brainstem intraventricular compartments as well as the spinal cord. With respect to its evaluation now, so imaging, you could see a solid or cystic mass that is iso to hypointense to brain on T1 MRI or hyperintense on T2 and heterogeneous enhancement. With respect to histology, the hallmark is the astroblastic pseudorosette, which is the tumor cells arranged in a radial pattern around the blood vessels, which is in the picture. And with respect to treatment and prognosis for these patients, so maximal safe resection is associated with a longer overall survival, but radiation and chemotherapy are options when surgery is not feasible. And for the prognosis, 5 and 10-year survival rate, so the 5 would be about 90% and 10-year would be about 50% respectively. And on an MRI now, so this is a classic MR imaging of a astroblastoma in a 3-year-old female patient on images A and B. These are axial T2 weighted images, and it shows a large, well-circumscribed, heterogeneous supratentorial mass with a peripheral cystic changes, which would be the arrows. And note that the solid component of the mass has a heterogeneous bubbly appearance in its center. C and D now these are axial post-contrast T1 weighted images, which show a rim enhancement of the cystic component, which is the arrows, and a heterogeneous enhancement of the solid component. In this case, this tumor was malignant. So these are my references, and that was the end of my presentation.